Okay, we can go ahead and get started since we have 4 speakers today. Thank you all for being here. I'm Rachel Kackmar. I'll be the moderator. I am an associate professor at the University of Colorado and a clinical service director for OB Anesthesia. I'm also the incoming chair of the COBA. So here's some of our statements and guidelines coming up. Everyone saw the learning objectives, and I want to just quickly introduce our speakers so we can get to the actual meat of this program. Okay. Dr. Nakia Hunter will be one of our speakers talking about the COBA statement on providing psychological support for obstetric patients. She's a Detroit native and board-certified anesthesiologist with specialization in OB anesthesia. She serves as associate professor and PD of the Obstetric Anesthesia Fellowship at the University of Illinois in Chicago, and her work centers on simulation-based education and advancing maternal health equity. Also, it's my pleasure to introduce Dr. Manny Vallejo. He's a nationally recognized leader in anesthesiology and medical education. He's currently a professor and associate chair of anesthesiology at the University of Florida in Jacksonville. Prior to this, he's held several key leadership roles at other institutions, including West Virginia University, where he was the chair of anesthesiology and later the associate dean and designated institutional official, or DIO, for the GME office. He's also served as the director of obstetric anesthesia and a fellowship director at McGee Women's Hospital at UPMC. And he's held faculty appointments in anesthesiology, obstetrics and gynecology, and medical education. Dr. Vallejo is widely known for his passion for teaching and mentoring, and he's earned numerous awards for this, including the SOAP Teacher of the Year Award, the ASA and SEA Distinguished Educator in Anesthesiology Award, the WVU Chancellor's Master Clinician Award, and the ACGME Parker J. Palmer Courage to Lead Award. In 2025, he received the inaugural SOAP Mentoring Excellence Award. And beyond academic and clinical work, Dr. Vallejo has served as president of SOAP and currently chairs the ACGME Anesthesiology Residency Review Committee. He will be speaking to us about evidence-based clinical practice guidelines on PDPH. Dr. Girish Joshi is a professor with tenure in the Department of Anesthesiology and Pain Management at the University of Texas Southwestern Medical School in Dallas. He's an attending anesthesiologist at Parkland Health, and he received his medical degree in Doctor of Medicine in Anesthesiology from the BJ Medical College, University of Pune in India. He received his fellowship in anesthesiology from the College of Anaesthetists in Ireland, and then a Doctor of Medicine degree from the University of College, Dublin. And he's a diplomate of the ABA. He has published numerous original articles, review articles, and editorials in several high-impact journals. He's been an invited speaker at national and international conferences and is an executive editor for ANA and section editor for Up to Date. He is also the past president for the Society of Ambulatory Anesthesia, or SAMBA, and the Society of Anesthesia and Sleep Medicine. He's also been a past president of the TSA. He serves on the board of directors for Accreditas Global, which is a subsidiary of the AAHC, and he's received distinguished service awards from both SAMBA and the TSA. He's a member of the Prospect Working Group on the European Society of Regional Anesthesia and Pain Therapy, which is an international collaboration of anesthesiologists and surgeons that formulates evidence-based procedures, specific pain management recommendations. He will be speaking to us on the clinical practice guideline for the safe use of GLP-1 receptor agonists. And to lead us off today will be Dr. Grace Lim. She's a distinguished obstetric anesthesiologist, a clinician scientist, and national leader in maternal perioperative care. Dr. Lim holds the rank of professor and has built a translational research program focused on medication safety in pregnancy and lactation, looking at personalized approaches to anesthesia and patient safety in the obstetric populations. She's overseen the expansion of high-quality obstetric anesthesia services and multidisciplinary perinatal care at her institution, and her leadership has informed national guidelines and consensus statements through roles on the board of directors of SOAP and advisories with ACOG, the AIM, and the ASA. Her research has been funded by NIH, PCORI, and institutional grants and spans peripartum pain mechanisms, opioid-sparing analgesia, and maternal safety, with particular attention to vulnerable and special populations. Please join me in welcoming Dr. Lim, as well as the rest of our esteemed speakers for this panel.
Thank you, Rachel, and welcome to this session. We're really excited to go through many of these consensus statements, and hopefully there will be some time at the end for Q&A and discussion. I'm going to talk about the consensus statement on pain management for pregnant patients with opioid use disorder. Very briefly in the time I have with you, I'll go over basically some general principles as it relates to these to this statement. I'll then distill as much of the statement as I can into some high impact clinical points. That was a very hard task to do, and I'll encourage you with a lot of QR codes to peruse the complete statement for your own clinical practice. And then finally, we'll go into risk mitigation and future directions as well. So essentially, in response to the lack of information and evidence to guide clinicians on how best to manage pain in patients with opioid use disorder, the Society for OB Anesthesia and Perinatology, the Society for Maternal Fetal Medicine, and the American Society for Regional Anesthesia and Pain Medicine got together and we devised this consensus statement. It was devised and based on a systematic scoping review that was conducted 2 years prior, in which we defined the key clinical questions that needed to be answered. And the product of this was co-published in both Anesthesia and Analgesia, as well as the American Journal of Obstetrics and Gynecology, because we wanted to enhance dissemination to both the obstetrician and anesthesiology communities. So there's your QR code. We'll highly encourage you to peruse that because an 8-minute segment is not going to do this statement justice, but I'll do my very best. Methodologically, we used the ACCAHA grading system, which was used to classify the clinical recommendations. That was based both on the strength of the recommendation as well as the quality of the evidence that supported it. So if you look at the class of recommendation, that describes how strongly a particular intervention is recommended, and it ranges from strong levels of endorsement to outright discouragement because of risk for harm. The level of evidence reflects the quality and the reliability of the supporting data, and randomized controlled trials represent the highest level of expert consensus applied, and we apply that when the high quality data are lacking. So in developing this consensus statement, as an expert panel, we worked very diligently to assign each recommendation both a class of recommendation as well as a level of evidence. So there are strong recommendations, which were classified as class 1, and those will indicate interventions that are clearly having benefits that outweigh the risks. They're supported by the best available evidence, whether from trials or from well-established clinical experience. Moderate recommendations will have class 2A, and that is suggesting an intervention that's likely beneficial but requires further validation and research. Weaker classifications like 2B are going to have reflect areas where evidence is limited or conflicting. And when the panel identified practices with no proven benefits or potential harm, those were designated as class 3. So I highlight this because the hazard that we have when we run consensus statements and publish them is that it might give everyone this false sense of security that we know everything there is to know about these topics and this is the way to practice. But that really is not the intention. The intention is to provide some guidance and some uniform practice considerations, while also highlighting where we need to continue doing research so that we can generate better evidence to guide our practices. So there are 3 parts to the consensus. The first is prenatal optimization, the next is labor analgesia, and the final is postpartum analgesia and optimization. And there are 3 general principles that underpin each of the consensus opinions, and these are essentially a balanced approach. We want to optimize pain management while minimizing opioid use and withdrawal risks. Multidisciplinary care, so a coordination between obstetricians, anesthesiologists, and addiction specialists is going to be important. And finally, individualized care plans, so tailoring pain management based on patient history, medications that are being used for opioid use disorder like methadone or buprenorphine, and comorbidities. So now I'm going to try to zoom in as best I can and kind of give you the high-level, clinical takeaways here. So one of the strongest recommendations from the consensus is that early neuraxial analgesia should be offered to all pregnant patients who have opioid use disorder. And that is based on evidence that it significantly reduces the need for systemic opioid analgesia in labor, which is particularly important for this patient population. And so the consensus panel here assigned this level of evidence of BNR, which means that it's supported by moderate quality evidence from non-randomized studies. The strength of the recommendation was class 1, meaning that we judged that the benefits clearly outweigh the risks. Additionally, the consensus statement emphasizes the importance of using shared decision-making here for this modality. And so while we highly recommend epidural analgesia, you have to engage in those conversations early with your patients and address any concerns that they may have so you can tailor the plan to their needs. The consensus also reinforces that our standard low concentration local anesthetic epidural solutions combined with lipophilic opioids like fentanyl or sufentanil or other adjuvants, those are going to remain the best practice for this patient population. So don't remove those things simply because they have a history of opioid use disorder. So to sum up over here, the epidural placement really should be offered early, strongly recommended, encouraged, administered using neuraxial medications that are standard. And the idea here is to improve pain control and maternal outcomes, but do this in a shared decision-making way. Another takeaway here from the consensus is that opioids should not be routinely prescribed after a vaginal delivery. And that is a critical point because we know that opioid exposure in the postpartum period can increase the use, the risk for return to illicit use in patients with opioid use disorder. So instead, you want your pain management approach to be structured and multimodal, using NSAIDs and acetaminophen as a first-line therapy, particularly in vaginal deliveries. The recommendation states that the opioids should only be considered in unusual cases, such as when there is severe pain that is unresponsive to standard treatments or when there's high-degree lacerations, for example. But even in those cases, the opioid prescribing really needs to be limited and surgical, very short duration, like potentially a 3-day supply is what was recommended, but that is an expert level of evidence only. And really that needs to be done in collaboration with the patient's treatment provider who is managing these things on an outpatient basis. So some coordination there is also recommended. This is a class 2A grade of evidence, which means that the benefits of avoiding routine opioid use is likely going to outweigh any of the risks. But once again, the level of evidence here is expert consensus only, so we really do need more studies in these areas as well to firmly establish this as a best practice. So the key takeaway here is that when managing postpartum pain, the default approach should be scheduled NSAIDs and acetaminophen and not opioids unless absolutely necessary. If it is judged to be necessary, using short prescribing intervals with a short follow-up period and heavy coordination with the outpatient team that will be monitoring those things after discharge is essential too. And so the next recommendation here is that for patients who are receiving medication for opioid use disorder, so this consensus is very, very clear here, methadone, buprenorphine should be continued during labor and delivery, should not be stopped. It also goes further than that and makes some suggestions as to how to potentially optimize dosing so that you're getting the most analgesic benefit out of it without increasing the risk for withdrawal. The class of recommendation here is a class 1, so the benefits are clearly outweighing the risk. And it's supported by moderate quality evidence. But it's also worth noting that pregnancy, compared to your non-pregnant patients, alters the metabolism of these medications. And so that means that dose adjustments may be necessary during pregnancy. Methadone is going to have increased clearance in pregnancy because of CYP enzyme activation. So the recommendation is to divide the methadone dose, if possible, to Q6 to 8 hour intervals. That is going to improve pain control in the peripartum period as well. And then once the delivery occurs, there has to be careful monitoring and even further titration because you may need to dose adjust once the CYP enzyme activation becomes more normalized in the 7 to 14-day period afterward. Similarly, buprenorphine may require more frequent dosing to maintain stability. And so while these are adjustments that you're doing to try to amplify or augment or maximize the analgesic potential of these agents, I want to heavily emphasize that it is not a substitute for neuraxial analgesia. And so they can be helpful for the peri-labor period in terms of amplifying and augmenting your multimodal strategies, but they are not going to be your savior when it comes to labor analgesia. That will still remain your neuraxial techniques. The other key emphasis here is on what to do if you have for opioid antagonists. I think normally we have things like Nubane or other antagonists available for opioid-induced pruritus. For patients who have opioid use disorder receiving medications like buprenorphine or methadone, don't use those. That will increase your risk for withdrawal. And so really your best options here, if you're concerned about the risk for opioid-induced pruritus in this patient population, is to potentially either remove the opioids from your neuraxial solutions or try some atypical agents like 5-HT3 antagonists such as ondansetron to treat pruritus, but don't use the antagonists. You will precipitate a withdrawal reaction, which that can be very challenging to treat. And then the other, one other clinician recommendation here is that collaboration is really important. So for pregnant patients with opioid use disorder or those who are receiving chronic opioid agonist therapy, these patients are at higher risk for increased pain and elevated analgesic needs during and after delivery. Lots of data that is coming out showing not only in experimental situations, but also clinically how this phenomenon of hyperalgesia is true. And so the consensus is strongly recommending doing antenatal anesthesia consultation to coordinate care so that you can plan more in a team-based way with anesthesiology, obstetrics, and addiction medicine to make a plan that supports the patient's priorities and decreases their risk for exposure to opioids if that's something that's important for them to avoid. Finally, neuraxial opioids and regional blocks should really be prioritized as much as possible in order to avoid the need for systemic opioids in these patients. The consensus supports the use of abdominal wall blocks like TAP blocks or continuous wound infiltration as part of a multimodal analgesia approach, particularly in situations of cesarean delivery. And so while the evidence supporting these techniques in this specific patient population is somewhat limited, there is reasonable levels of evidence supporting the use of these techniques in other contexts, and they can be considered extrapolatable to this patient population with these special conditions. So the recommendation is classified as 2B, which indicates that the benefits may outweigh the risks, but it does also acknowledge the need for better research in this area and the need for better evidence. So ensuring safe and effective pain management for patients who have opioid use disorder is going to be require a lot of thoughtful approaches to risk mitigation. And one of the areas that the consensus does touch on, which none have previously discussed, is urine drug testing. This becomes very important for the peripartum patient population because there are implications for how the mother is treated and what happens with the baby after if there are, let's say, false negative screens as a result of opioid exposure in the labor and delivery period. And so testing really should be done. The recommendations are that testing for urine testing should really only be done when clinically necessary and with informed consent of the patient. So this is a key thing that's going to potentially require a little more coordination in your practice when you take this back home, because at this moment there's plenty of practices that probably draw those tests without consideration to what's been going on with labor analgesia management. But this becomes a very important point when drug tests might come back positive and patients were not aware of these things at all. The next thing is education and communication. Clinicians really do need some clear guidance on how to navigate pain management for this patient population, and it's been recognized that stigmatization of this particular condition can be a barrier to talking about what the shared goals might be. And so there does need to be some concerted, focused attention on removing some of the stigmas and barriers to opening up those conversations with patients, and also a shared education plan with clinicians so, to improve the quality of care that's provided in that context. And then finally, we do really need research. There's still many unanswered questions about the best strategies for pain control in patients who have opioid use disorder who become pregnant, including how exactly to optimize those multimodal approaches, how to individualize targeted opioid use when it's appropriate, and how to track the long-term maternal and infant outcomes related to these things. But addressing those gaps is going to be very important into improving outcomes and establishing best practices. So to summarize these key clinical points, for pregnant patients who have opioid use disorder, our approach should really prioritize early neuraxial analgesia in a shared decision-making way, structured multimodal pain management, and continuation of the medication for opioid use disorder during the peripartum period with attention to titration of medication as necessary. And that is going to help optimize pain control and minimize the need for systemic opioids. And then equally important is multidisciplinary and individualized care. So proactive coordination between the anesthesia team, the obstetrics team, and addiction medicine teams is going to be really important. and essential to deliver safe, equitable, and patient-centered pain management for these patients. Thank you.
Hi, everyone. Thanks for joining this late afternoon session. So today I will be highlighting or sharing some highlights from the ASA statement on providing psychological support for obstetric patients. And I did include a QR code if you want to access the full statement and follow along. So during this talk, I will be outlining the framework for understanding childbirth-related trauma and also presenting some practical strategies for trauma-informed care that will help anesthesia providers to facilitate a safe and happy birth experience for mothers, which is every woman's dream. So we'll start by defining what a positive birth experience actually is. So it's defined as one where mothers feel supported, safe, and also respected throughout the birthing process. And as anesthesia providers, we are uniquely positioned at the forefront of maternal safety and comfort, and our actions, how we communicate, care for our patients, play a powerful role in shaping this experience. But the reality is that childbirth is highly unpredictable, it's complex, and for some it can be deeply traumatic. In season 2 of the Retrievals podcast, Clara, who's actually a labor and delivery nurse at my own institution, she bravely shares her experience, traumatic experience during her cesarean delivery. And that also happened at our hospital. So as she recounts the events in the operating room, she describes feeling severe pain and also confusion due to heavy sedation. And she says, I could still feel pain. I was hallucinating and couldn't make sense of what happened. But I remember begging them to stop. So this is the voice of childbirth-related trauma. So it's when a patient's expectations of a positive birth experience is met with suffering, and it can leave lasting psychological imprints on patients. By definition, childbirth-related trauma is the interactions or the events during childbirth that cause overwhelming, distressing, and emotional reactions. And that can lead to short and long-term impacts on women's mental health and also their physical well-being. And when these psychological injuries go unrecognized, they can contribute to devastating mental health outcomes. So for years, of course, we have focused in on maternal mortality that has centered around medical conditions, so like hemorrhage and infection, but recent MMRC and also CDC data tell a different story. So the leading causes of maternal death in the U.S. are now homicide and suicide, and over half of them involve firearms. And substance use disorder was identified as a contributing factor in about 25% of pregnancy-related deaths. And equally alarming, more than 1 in 5 preventable deaths is tied to mental health conditions. And beyond mortality, nearly half of patients describe their childbirth as traumatic. And these negative experiences also impact maternal morbidity. Many women can develop anxiety and depression, childbirth-related PTSD. And then it doesn't only affect the mom's recovery, it also affects infant bonding, breastfeeding, and then also adverse child development. So these statistics remind us that mental health is not separate from maternal health. It is maternal health. So the next step is understanding why and what we can do as anesthesia providers to try to prevent this from happening. So it starts with knowing and understanding the patient factors that contribute to traumatic birth experiences. So patients with prior trauma, like intimate partner violence or also childhood sexual assault, are especially vulnerable. So for them, even minor triggers like touching the patients during your epidural placement can trigger these traumatic memories. Patients with pre-existing anxiety, depression, opiate use disorder, and also PTSD often experience a heightened pain perception and also emotional distress in the peripartum period. In fact, childbirth-related PTSD impacts up to 6% of postpartum patients, and 12% of these women actually report having a history of post-traumatic stress. So also previous traumatic or negative subjective birth experiences can also cause a significant or increases the risk significantly. And that includes like prolonged labor, cesarean delivery, whether this is planned or unplanned. and then any previous complications during pregnancy. And they all add layers of uncertainty and also fear for our patients. But trauma isn't only triggered by the actual medical complications. When there are unmet expectations, like when the birth experience doesn't actually align with what the patient hopes to happen, what happens is that the patients are left disappointed, and then they have feelings of failure and also loss of control. And even provider pressures for epidural placement can also trigger or has been linked to childbirth-related trauma. Also, a lack of social support. So whether this comes from a family member, close intimate partner, and even medical providers can have a significant emotional and psychological impact on our patients. And then lastly, of course, having any complications throughout the peripartum period can also trigger childbirth-related trauma. So what we do, our actual moment-to-moment actions when we're interacting with the patient matters. So intraoperative pain during cesarean, that actually occurs in up to a quarter of cases, and even one episode of untreated pain or a dismissed concern can leave a lasting psychological imprint. And likewise, untreated epidural breakthrough pain, even post-dural puncture headache, and nerve injury can amplify that sense of feeling hopelessness. So while these subtle risks may make a case seem routine to us as providers, but the actual lived experience by our patients can be different. So recognizing and screening for these patients do help prevent unintentional physical and emotional harm. And evidence shows that supportive trauma-informed care is one of the most effective ways to reduce childbirth-related PTSD. So now let's review some practical strategies for trauma prevention. The Substance Abuse and Mental Health Services Administration, or SAMHSA, has a good foundational framework for practicing trauma-informed care, and they named this their 4Rs model. And this serves as a guide on how we can recognize and respond to patients that may be experiencing trauma. So the first step is realizing that trauma is common. And the next step is to recognize the risk factors and the clinical signs of trauma. And then how we respond to this at-risk group, and that's by integrating supportive, patient-centered strategies into every encounter. And finally, resist re-traumatization, meaning taking active steps to prevent re-triggers or re-exposure to those triggers. And this 4Rs model, it lays the foundational framework for psychological safety, which is the point of trauma-informed care. So building on SAMHSA's 4Rs framework, the ASA statement expands on this trauma-informed care model into 3 practical domains for anesthesiologists. And the super strategies are sovereignty, support, and also sharing. And these are suggested best practices for promoting a positive birthing experience through trauma-informed patient-centered care. And this model is pretty much like a simplified approach to framing our mindset to deliver humanistic care to our patients. So the first domain is sovereignty, as I mentioned. So that's going to encourage patient-centered actions and communication styles to maintain a sense of autonomy. And then support, of course, that is going to encourage providers to be present and also provide reassurance during critical moments throughout the birthing process. And then sharing, that involves actions that's going to maintain open and transparent communication with our patients. So while these super strategies, these practice models, it sounds minor, but they're highly protective for our patients. They have a power to actually reinforce our trust, reduce anxiety, and also improve the clinical and the psychological outcomes of birth. So when we combine SAMHSA's 4R framework with ASA's super strategies, we can see how easy it is to implement trauma-informed care into our daily practice. So the 4Rs represent mainly the mindset, how we approach maternal care, while the super strategies gives us the methods or actionable items to implement trauma-informed care. So now that we realize that many patients have trauma histories, that will allow us to expand our medical preparation to include psychological support. So when we recognize, So when we realize that these patients have trauma history, that allows us, like I said, to expand our approach to include the psychological component. So it starts with patient screening. So review medical charts for mental health conditions as thoroughly as you would for mental health conditions as you would for medical comorbidities. So consider expanding your high-risk OB anesthesia consultations to include patients with previous birth trauma, those that have also pre-existing mental health conditions. And the next step is responding. How do we respond to these vulnerable patients with supportive patient-centered care? So one way that we can do that is striving for intentional human connections, especially during those distressing events. So when we communicate with our patients, make sure that you maintain a calm tone, provide simplified explanations without using medical jargon, and offer continued reassurance about what's going on, validating their concerns while trying to, of course, maintain respect for their preferences. A big step of what we do in our care, and probably the single most important strategy that's within our control, is to differentiate anxiety from pain. And you can do this by simply just asking a patient directly. So when a patient has untreated anxiety, what can happen is that can escalate to physiologic stress, and then the patient will, of course, display those symptoms. And that can actually lead to increased pain sensitivity and trigger a vicious cycle between pain and anxiety. And additionally, anxiety may increase the risk of postpartum depression, PTSD, and also thoughts of suicide. So it's okay to offer anxiolysis to these patients pre-procedurally and also perioperatively. And if the patients display these extreme signs of fear and hypoalgesia during block placement, you should consider talking to the patient and having a more patient-centered discussion around it. So, of course, you want to mention the risk factors or the side effects in the maternal and the fetal safety profile for it, but then you also want to highlight the benefits of it. And the statement actually includes some dosing recommendations for some common anxiolytic agents. And another effective way of easing a woman's fears is to allow a support person to be present whenever it's possible. So if the patient complains of pain during cesareans or experiences pain during their labor course, make sure that you address it promptly with the goal of optimizing their care. And this could be achieved through altering the concentrations of your local anesthetics, also increasing the opiate dosing of your neuraxial analgesics, and then also considering other adjuncts neuraxially, including clonidine. And the ASA has provided thorough guidance on this in their statement for pain during cesarean delivery and also adjuvant medications during intraoperative pain for cesareans. And that's the QR codes that are included there. And then please remember that optimal pain control extends into the postpartum period, ideally for at least 24 up to 48 hours. So you want to employ any of the ERAS protocols for cesarean, and the suggested best practice is to use neuraxial morphine when possible and scheduling acetaminophen and also NSAIDs. And additionally, make sure that you have close postpartum follow-up to ensure that the patients do have control of pain. And then you want to continue any pre-existing chronic pain meds or any psychotropic medications in the postpartum period. And then lastly, resist re-traumatization. So that means avoiding, of course, these common triggers. So be mindful of the distressing sensations like being gentle when you're palpating patients before placing epidurals. Be aware of your language. So avoiding phrases like don't move, because this can create fear and also distress in a patient. Or telling a patient that the local infiltration feels like a bee sting or feeling nasty. And research has shown that the verbal communication with negative emotional context can actually heighten the patient perception of pain. So instead, use neutral language like, I am putting in the local numbing medication now, and then also use positive suggestion and reinforcement. So you can tell patients that they're doing well and then check in with them about how they're feeling throughout placing the epidural or any other procedures. So as I mentioned, being mindful of your tone as well. Because if the patient senses that you're nervous or if you're yelling, that can actually compromise patient trust and then also create more fear. So optimizing the pain control, as I mentioned, and medical management, it does also reduce the likelihood of needing to make any emergency interventions. And also respecting the patient's privacy, so making sure that you ask for permission before you expose their back or before you touch them. And then when you're in the operating room, avoid restraining patients because you want to facilitate mobility of our patients, or even allowing them to hold the mask before you induce general anesthesia for pre-oxygenation. And then also optimizing, like I said, the pain control. So you want to optimize your actual dosing of the epidurals that will facilitate them to be able to move their legs. So you don't want to dense in their blocks so much that they have a motor blockade and feel a sense of lack of control. And then more broadly speaking, trauma-informed care, it means practicing those true patient-centered care. So being transparent and educating patients during key events, providing close follow-up after complications, and ensuring these patients have access to ongoing mental health services, and providing those resources if available. So the ASA statement does also list a detailed list of hospital and also community-based resources for patients if you want to access that as well. So all in all, at the heart of these strategies is one goal, and that's the experience, making sure that the patient feels safe, supported, and respected. So in closing, just remember that trauma-informed care is not just a separate protocol. It's a mindset that starts with awareness and ends with taking action. And as anesthesia providers, we have the power to make a meaningful impact through mindful, intentional, trauma-informed care. Because ultimately, if we don't name it, we don't treat it. And if we don't treat it, we risk losing mothers to preventable suffering.
Okay, good afternoon, everyone. Thank you for going through this. And we got one more speaker to go, and Rachel will let me know when I need to try and finish up. So in the interest of time, let's get this going. And let's see, how do I skip? Let's see, I see it, I'll do the arrow. Okay, so we had a multidisciplinary group, and we were talking on a post-oral puncture headache. So the process was that our idea was that the post-dural puncture headache treatment lacks uniformity in clear evidence-based guidelines. So our goal as a multidisciplinary group was to provide a standard approach for PDPH management. So quickly to go through this, step one, here's all the groups, multi-society groups of which SOAP was included. Step two, we did a problem definition, and we came up with 10 clinical questions that needed to be addressed. Did a literature search, and then we did methods, and then what we decided is we came with the 10 clinical questions, and we provided a narrative. Then we did round one voting, which was a modified Delta approach, where we tried to get agreement, 100% agreement. So ones that had 100% agreement automatically passed. The ones that did not went back to the group to redefine, and then we tried to get at least a set greater than 75% agreement, of which we were able to attain on the 10 questions. And then we have our summary of findings. So that's pretty good. I mean, going through that pretty quick, okay? So then how we decided, so we used a U.S. Preventative Services Task Force grade guideline. So we graded it. So basically the grade was for just suggestions for practice. So it went from A, B, C, D, and I. So A, I can think of it as always. It's always recommended for guidelines. B, it's beneficial to do it. C, you can use it. You cannot use it too. D is discouraged, and I means insufficient evidence. So we'll go through this. And then that we also did levels of certainty, which basically what is the evidence. So high level of certainty means that the evidence out there, the literature is really strong. Moderate, it's like, well, there is some literature, but the number, size, and quality is really not up to where it needs to be. And then there's low level of evidence. So you'll get all these gradings and you'll see it. And I tried to basically color coordinate it so you can get an idea of where we're at, so I can get done within 10 minutes and so I keep on time. So of the 10 questions, question one, when should a PDPH be suspected? So came up with the statement that really if you develop a headache or neurological symptoms that's improved by lying flat, so there's a positional component. So the recommendation is that all patients that have neuraxial anesthesia should be monitored for PDPH symptoms, and then they should report their symptoms to their physician. Question two, what are patient factors associated with PDPH. So age is that's younger adults, so we all know that. So basically, and also female gender. So women that are young at the highest level. So that's really the clientele that we basically give the neuroaxial anesthesia to. BMI. So even though you might think it is, that it's inconsistent. So BMI is not consistent as a factor for post-dural puncture headache. How about other comorbidities? Prior headache. So if the patient has a prior headache of a chronic, recent, or prior PDPH, that goes along with an increased risk for post-dural puncture headache. Now, what about migraines? It is unclear. So if they have a migraine headache, does not necessarily mean that they're going to get they're at higher risk. Smoking is insufficient. So smoking may be okay for post-op nausea and vomiting, but there's insufficient evidence that smoking is protective for post-dural puncture headache. Depression, insufficient evidence. So it's been suggested that if moms are depressed, that there are increased likelihood. That is not consistent. Also, active pushing. There's a theory out there that if you have a post-dural puncture headache or a wet tap, that the pushing during the active second stage of labor increases the rate. The evidence is inconsistent, low level of certainty. Needle type. So that basically this slide goes over cutting and non-cutting. So it's suggested a statement that you really should use pencil point needles, it decreases risk. So we all know that. There's insufficient evidence, though, the type of the pencil point needle that you're going to use. So recommendation, routine use of non-cutting pencil point needles is recommended. How about needle size? So if you're using a cutting needle, size does matter. Pencil point, it really does not matter. So a cutting needle, you should use a narrow gauge. So then they basically a recommendation if you're doing LPs and they want to use a cutting needle. Statement, narrow gauge, non-cutting needles are recommended, and there's limited evidence on a specific type of pencil point needle. Okay, so question 3 again, procedural characteristics. Needle insertion, there's no evidence that the midline or the paramedian approach is better, so it does not support it. In bevel direction, if you're using a cutting needle, it's recommended. This is just cutting, not pencil. Cutting needle, the bevel should be parallel to the spine, long axis is preferred. Loss of resistance to air or saline, insufficient. Whatever you use, if you use loss of resistance to air, if you use loss of resistance saline, both are fine. There's no evidence that one is better than the other. And then obviously the higher number of LP attempts that you do, then the more likelihood increased risk. Operator experience, yes. So evidence does, if you have a greater operator experience, it decreases risk, although the overall benefit is very small. So just so you know. So there's a learning curve, but the overall benefit is not that much helpful. The type of neuroaxial block, all neuroaxial blocks have a similar incidence of PDPH risk. As far as the block level, there's no evidence that a certain block level is better than the other lumbar area. Patient positioning, that actually evidence does support performing the block in the lateral decubitus position. So probably if you get a wet tap, they're already lying down, so there's less likelihood. So evidence does suggest that you do it, although when I work with residents, I just want them to get it, and I think it's a lot easier if they sit up and you align your axes and you get it in. So that's my main concern, but that's what the evidence says. So probably if you're using a cutting needle, yeah, it probably would be better to do a lateral decubitus. A traumatic or atraumatic tap, the needle choice does not necessarily mean you're going to get an atraumatic or a traumatic tap. So I thought that was important too. Intrathecal catheter placement. So remember, if you get a wet tap, to put an intrathecal catheter for 24 hours, there's insufficient evidence that it decreases risk. Although it can be used, the recommendation, which is grade B, which means beneficial, that it can provide sufficient analgesia and anesthesia if you need it. So someone that's morbidly obese, difficult airway, maybe severe preeclamptic, platelets are going down. If you have a form of it, go ahead and use it. It's good to use, and it's beneficial to do it. Prophylactic epidural blood patches, variable success. And basically it's recommended in a statement that not all patients who get a wet tap are going to develop a post-dural puncture headache. So you don't necessarily have to do a prophylactic epidural blood patch when not all patients will develop. And then also you may expose some patients to unnecessary risk, like aseptic meningitis and things like that. So recommendation is a prophylactic epidural blood patch is not recommended. Bed rest, inconclusive. This is prophylactic, so you get a wet tap, bed rest, it's inconclusive. Actually, it's recommended that it's not recommended because of the hypocoagulation of pregnancy. Women should really get up moving around. Epidural and spinal injections of like intrathecal morphine, dimorphine, Hespan, dexamethasone, and saline, there's insufficient evidence. So grade I, insufficient. So it's really not recommended. And then pharmacological measures for prophylactic, so paracetamol, caffeine, morphine, dexamethasone, aminophylline, it's insufficient evidence. So this is prophylactic post-dural puncture headache management. Now, also non-pharmacological conservative measures, bed rest, there's insufficient evidence that support routine bed rest, and we talked about that. Fluid therapy, recommended that you have fluid therapy. Oral is much better than IV, so it is recommended. Abdominal binders, insufficient evidence. Aromatherapy, insufficient evidence. There's just not enough information out there to make a good decision, so it's not recommended. So now we have treatment. So we're going to treat it. We have a post-dural puncture headache. Oral analgesia is recommended. So you should give multimodal analgesia, acetaminophen and NSAIDs, and also short-term use of narcotics is okay, but it's not recommended for long-term use because you don't want to get them addicted. Caffeine can be given in a daily dose of 900 if you're breastfeeding 200 to 300. So and then all these other medications like hydrocortisone, theophylline, gabapentin is insufficient evidence. Grade D should be discouraged. Okay, so then I need to move. I got 2 minutes. I'll do my best. So acupuncture, insufficient evidence. Sphenopalatine blocks, insufficient evidence. Epidural and spinal morphine, insufficient evidence, grade D. Now, grade occipital nerve blocks, so you do 2 blocks behind the neck, it can be recommended. So if you use a spinal needle, it's 22 gauge or less, it can be helpful, although you need to let the patients know that they may need to get an epidural blood patch for definitive treatment. So that's it with that. And procedural, here's all the other insufficient evidence on epidural gelatin, Hespan, dextran, fiber and glue. It's been associated with aseptic meningitis and also anaphylaxis. So it's recommended not to use, and if you're going to use it, you really should be reserved when you can't give autologous blood, or if it's not no other option than to use it. I personally would not use it. Okay, so management to confirm diagnosis. You don't need procedural imaging like head CTs, and that's not needed, or MRIs. So evidence is insufficient that you need it. Now, if they do have a non-orthostatic headache, if the headache's longer than 5 days, then you can get neuroimaging. If you have focal neurological deficits, yes, you should be using it, and then you also need a good referral. So let me try and move on here right quick. Contraindications, if you're above 70,000 platelet count, it's fine to use. And then also, if they're on antithrombotics, you should use stay adhere to the established guidelines. So whatever SOAP says or ASA or whatever, you should use those guidelines. You don't need recommended prophylactic antibiotics. It's insufficient. And if they're febrile, you should consider, or if they have signs of a systemic infection, you should probably defer the procedure. It's not good to do. So other indications, if they fail to respond to conservative management, then you should give an epidural blood patch. Severe neurological symptoms, an epidural blood patch should be considered. So if they have diplopia, tinnitus, things like that, you should be considered. Also, if you're going to perform a blood patch less than 48 hours, you need to let the patient know that the chances of a repeat epidural blood patch are much increased. And then the remissions are not as high as we thought it used to be. It used to be reported 90% or better. It varies from 33 to 90%. And I got to get moving here. Okay, timing level. So recommendations, less than 48 hours, repeat epidural blood patch is likely. They should receive regular follow-up care. And then it's recommended too, when you do the epidural blood patch, you should do it the exact site. If you can't do it, you should do one level lower. And then you can also use fluoroscopy guidance only in the transfemoral approach, only is like if they had other like surgeries and stuff like that, it makes it hard. So it's okay to use that and to do proper referral. Volume 15 to 20, anything above 30, it does not impair to improve the symptoms. You can use ultrasound if needed for anatomical guidance and radiographic guidance based on patient-specific factors, surgical factors, things like that. Blood cultures, you do not need routine blood cultures, and it's not supported. Immobilization, so after you get a blood patch, it's not definitive of how much time you need to be immobilized, and you can get a labor epidural after you get an epidural blood patch. It should be withheld. And a couple more slides. Informed consent, and they should be informed about the risk of chronic headache, chronic backache. It should be injected slowly and in small increments. And injection should be stopped and resumed later, and then stop if it's going to cause more harm than good. And I think last slide here, there is an association with post-dural puncture headache, chronic backache, depression, cranial nerve palsy, subdural hematoma, and cerebral venous sinus thrombosis. And they should receive proper follow-up afterwards. And I think that's it. Thank you so much, and hopefully I wasn't too fast.
All right, last one.
Thank you. First of all, I want to thank the meeting planners for inviting me. It's a great honor. These are my conflicts of interest, which are not applicable. And very briefly, we know GLP-1s are increasingly being used, not just for diabetes and blood weight loss, but also for other conditions such as cardiorenal conditions. And now more and more indications are going to come around for addiction, Parkinson's, Alzheimer's, you name it. And so we are going to see more and more of these patients. One of the concerns with the use of these drugs for us is the potential of retained gastric content and regurgitation and aspiration during general anesthesia and sedation. So there are so many guidelines. It started off with the ASA recommendations, and then there are at least 30 major international and national guidelines and consensus statements. The fact that we have so many guidelines, as they call guidelines, they're not really guidelines. They're basically consensus statements or guidances, because there is really no good evidence to provide us with good guidelines. Yes, there are many, many studies published in high-impact journals like JAMA, etc., but most of these studies are really flawed or of very low quality. So to last count, there were 105 studies that have been published in good journals, and literally all of them really do not provide any guidelines, or they are very bad studies. So keep that in mind. So what does one do with this much of confusion? Overall, having reviewed all the papers, there are 4 areas of controversy. The first area is, should I withhold the drugs prior to procedure or continue? Let's put this to rest. Now, majority of the recommendations suggest that GLP-1s should be continued. Though the ASA initially started off with saying withhold for one week, but at that now subsequent data shows continue. The other controversy is the fasting duration for solids. The ASA recommendation for fasting, as you know, the standard recommendation is 6 to 8 hours for solids. And others now recommend 24 hours for solids, and I'll go a little bit details for that one because it still remains controversial. The next is gastric ultrasound. There's no question that doing gastric ultrasound is helpful. It will allow you to determine if there's retained gastric content. The question arises whether you should do it routinely for every patient, and in a busy practice that may not be possible, or should we do it for selective patient population? And finally, appropriate aspiration prophylaxis. The basic stuff which we know what to do to prevent aspiration basically is, even if patient has retained gastric content, it doesn't mean that that retained gastric content is going to get regurgitated. Also, we don't know once they're regurgitated, will it be aspirated? So there are so many factors that involve. Typically, to prevent regurgitation, we should have adequate depth of sedation or anesthesia. The most common cause for regurgitation is inadequate anesthesia when the patient coughs and bucks, or when we attempt intubation, when they're not adequately paralyzed. What happens, and what we have seen in reports where patients have regurgitated in this patient population, is we're so worried about that patient's going to aspirate that we don't give them good sedation, or we don't adequately wait for relaxation. And we want to get the tube in so fast. So we cannot forget the bare basics of prevention for aspiration, which has been, safe practice is actually not safe practice. So as I mentioned, there is no controversy anymore with regards to continuation. Almost all good consensus says, please continue the drug. Now, with regards to fasting duration, the British Society just recently published, and that's been endorsed by the British Diabetic Association and 10 other British societies, that say standard ASA recommendation of fasting, that is 6 to 8 hours for solid. The ASA endorsed multi-society, multidisciplinary guidance, basically recommends fasting for 24 hours only in the high-risk population. I'll present to you what that is. While there are other two recent, you see, most of them are this year or just late last year. The other two societies, PACI and the Australian Society, recommend for 24-hour fasting for solids for all patients. In addition, they also recommend fasting for clear liquids for 4 to 6 hours. That means the patient cannot have anything by mouth for 4 to 6 hours. That goes completely against all the recommendations of the enhanced recovery, where we say, give them drink during the fasting period. Give them water, example. In fact, the current suggestion is the so-called 6-4-0 rule. I don't know whether you've heard that. Typically, what we have from the ASA guidance or guidelines, those are guidelines. 6-4-2, that means 6 hours for solids, 4 hours for milk, and 2 hours for clear liquids. The latest one is 6-4-0. Give the patient, if they're thirsty, give them some water to drink. That improves outcome. So this recommendation that they should have nothing by mouth, even water, for 4 to 6 hours does not go hand in hand. Water stays in our stomach for no more than 10 minutes, 250 mils of water. There's a lot of good data for that. So what do? I'll give you the ultimate take-home message. As I cannot emphasize enough, the whole recommendation is from very sparse and weak evidence. The recommendation for 24-hour fasting comes from just 2 papers, retrospective papers. One of them is a study which looked at patients with colonoscopy, undergoing colonoscopy or upper GI, and then they did ultrasound, and they found that those who were undergoing colonoscopy had less retained gastric content as compared to upper GI, and the hypothesis was because colonoscopy patients fast for 24 hours for solid, that's the reason. The other study is literally 20 patients in each group, bariatric surgical population. Same thing, they fast for solids for 24 hours. So please keep, and then those are the 2 reasons why, 2 studies where people say for all 24 hours for all patients. And then the Sparky group recommends clear liquids for until only up to 4 hours or 6 hours, But during that clear liquid fasting, that is the first 20 hours, they recommend more than 10% carbohydrate. There's no data for that. I don't know where they came up with. Literally nothing there. There is, in fact, data to suggest that in diabetes patient, giving carbohydrate loading causes more harm than good. And that all came from, if you remember, the enhanced recovery protocols that are now almost more than a decade old, all recommended so-called carbohydrate loading prior to the procedure. And that data was based on increased glucose or insulin resistance, and that's where it came from. But around the same time, there was observation and reports that patients with diabetes, if they got carbohydrate loading, they had hyperglycemia, either delayed cases or cancellation of cases. So the American Diabetic Association and many other societies now recommend not giving carbohydrate loading for diabetes patients. Well, they recommend carbohydrate loading. So what are the high-risk patient population? This is the patient population that needs to be identified based on the multi-society recommendation, which is what the ASA has endorsed with. And that is because once you identify the patient at high risk, which is what we do for in our regular approach to prevention of regurgitation and aspiration, that means you're going to do the right thing, do the rapid sequence induction for that. Dose escalation phase, there's very good data to show that patients after some time have tachyphylaxis to the GI effects, including the retained gastric content of the GLP-1s. And typically that happens during the dose escalation phase. Because of the GI effects, let's say Ozempic, I have no conflict of interest, typically they start at a low dose that is 0.5 milligrams, and the optimal dose in most cases is 2.4 milligrams. That's the max dose. They don't start with 2.4 milligrams for a start because otherwise there'll be significant GI effects. So that is that so-called dose escalation phase. It usually takes, and it's patient-dependent, anywhere between 8 to 12 weeks. So if there is a procedure, elective procedure being done, best is to avoid the elective procedure during that dose escalation phase, because after that, there'll be tachyphylaxis. And you won't have this concern of retained gastric content, and there's data for that. If a patient has GI symptoms, it's also correlated very well with presence of retained gastric emptying. However, the flip is not true. In other words, if the patient does not have symptoms, does not mean they don't have retained gastric content. So please keep that in mind. And finally, obviously, patients who have other comorbidities that can delay gastric emptying, or they are on drugs that can delay gastric emptying, will add to the concerns of the GLPs. The multi-society guidance also included high doses of GLPs and long-acting GLPs as a risk factor. But subsequent data now negates that. That's why this is all dynamic and live. Now we know that high doses or long-acting do not necessarily increase retained gastric emptying. Now, ultrasound point of view, though, as I mentioned, ultrasound is a good idea, but it's really not possible for everyone, and it's not possible to do it routinely. Not all of us are good at doing ultrasound, or we may not have enough time to do it. And therefore, we recommend only individualized approach to ultrasound, and this is the ultimate take-home message. I'm going a little faster, but in interest of time, because I know there'll be a lot of questions. Day before surgery, identify the high-risk population. This is the high-risk population here. Best is to avoid elective surgery in this patient population. But if you can't, then if they are in high risk, use liquid diet for 24 hours until 2 hours prior to surgery. That's the ASA recommendation. So avoid solids for 24 hours. If they're not in the high risk, standard fasting, standard approach. On the day of the procedure, if they have GI symptoms or do ultrasound. If they don't have GI symptoms or have followed the fasting, proceed. Ultrasound, if their stomach's empty, proceed easy. If the stomach's not empty or it's inconclusive, do rapid sequence induction. But again, during that rapid sequence induction, follow proper precautions, which we would do for all other patients. And there's shared decision making as well. So to summarize, I've already said this. To summarize, the aspiration risk is real, though it's very low incidence, but if we all know if it happens, the consequences can be dire. Evidence for all the guidance is almost sparse and poor quality. So based on that, keep that in mind, we recommend that identify the patients at high risk, give them clear liquids for 24 hours if they're at high risk. Very low threshold to do ultrasound, low threshold to do rapid sequence induction, and shared decision making. Thank you.